Hello everyone and welcome. Last time we discussed about the insulin, how it is going to get released, that is mechanism of insulin secretion. Now let's talk about some clinical implications of that, right? Or clinical significance, clinical aspect. Why? Because remember, whenever you are writing a theory exam, always write a clinical aspect. Why? Since your integrated learning is started, you do have some extra edge if you write the clinical implications in your exam. Definitely the examiner will give you 1 or 2 extra marks accordingly, right? So let's talk about the factors affecting the insulin levels. So now we are going to talk in terms of factors affecting insulin release. First of all, we'll learn what are those factors which are increasing the insulin level. So factors increasing insulin levels. Factors increasing insulin levels. Now what are those factors? Now first factor is, we know that the ATP production, if it is increased, what is going to happen? If more ATP is produced, the potassium channel will be closed for the longer time, and definitely the potassium, more and more potassium will be accumulated inside the cell, will cause more and more depolarization, will cause more and more opening of voltage gated calcium channel, and cause more and more exocytosis of the insulin. So definitely whatever products that are increasing the ATP production, those are going to increase the insulin release. Some examples, first and foremost, is the glucose. Glucose itself will cause glycolysis inside the beta cell of pancreas, which will cause all these cascade to be provoked, right? And then free fatty acids, we can write it as FFA, free fatty acids. Not only that, also the keto acids can increase the ATP. Keto acids, amino acids, I'll just write AA over here, especially the leucine and lysine. They are the one who increase the ATP production a lot and increases the insulin release a lot on stimulate the beta cell of pancreas. The second, let's talk about the potassium channel blockers. Now remember, if you give the potassium channel blockers, obviously the potassium channel will be blocked, that is the ATP dependent potassium channel of beta cell of pancreas will be blocked. More and more potassium will be accumulated inside, more and more will be depolarization, more and more will be the opening of calcium channels, more and more will be the exocytosis, right? So potassium channel blockers. Any example? The example is sulfonylureas. Sulfonylureas, which we give in the treatment of a diabetic patient, right? Why we give that? Because the insulin inside their body is less. If we give them the potassium channel blocker, it will solve the purpose, that is nothing but the cause of or increase the release of insulin. The third one is parasympathetic system. Now the parasympathetic nerves or parasympathetic system, they release the acetylcholine over here. Let's write parasympathetic nerves. So they release acetylcholine and they act on which receptor? They act on the M3 receptor. What they are going to do? Acetylcholine, parasympathetic nerve. Which nerve I'm talking about? Basically we are talking about the vagal stimulation. The parasympathetic nerve, what is going to happen when it is going to get stimulated? It will increase the secretion. Remember, rest and digest system. For digestion of the glucose and everything, we require what thing? We require insulin, and that's why the parasympathetic system help in the digestion by secreting the insulin, right? So that also helps in the insulin release. Then we do have GI hormones or GIT hormones. Any example of GIT hormone? So I can write most of the GI hormone, gastrointestinal tract hormone or gastrointestinal hormones, or most of the intestinal hormones. Most of the GI hormones, what they do is they increase the insulin release. Or insulin secretion. But remember, it is done best by two hormones. What are those two hormones? GIP and GLP, GIP and GLP. Now remember, the GLP are having many types, and especially over here we are going to talk about GLP-1. Now what is GIP and what is GLP? GIP, it has the previous name, or when it was discovered, it found out to be having the inhibitory effect on the gastric secretion. So that's why the scientists gave it the name as gastric inhibitory peptide. So gastric inhibitory peptide. But remember, as they got to know later on that it is not the main function of this GIP, but it is having the main function of insulin release. And that's why nowadays we call it as the glucose dependent. We call it as glucose dependent insulinotropic peptide. Glucose dependent insulinotropic peptide. So beforehand it used to be called as gastric inhibitory peptide, and now it is called as glucose dependent insulinotropic peptide. Insulinotropic, why? Because it increases the insulin release. And what is GLP? GLP-1 is nothing but the glucagon like peptide. Glucagon like peptide. Glucagon like peptide type 1. Now remember, they both start with G, right? And these two are increasing insulin. So there are two in are coming, right? So these two are increasing. They are the best hormone who can increase the insulin secretion at max, right? So these are the best hormone. So what they do, they both together, they increases insulin. They increase insulin. They increase insulin. Now over here, what they do, they increase insulin, and that's why if something is increasing insulin, they are called as incretins. So you just have to add a T in between, that is incretin. And this effect, if the insulin release is increased by these two hormones specifically, or by the stimulation of these two hormones, so definitely this is called as incretin effect. This is called as incretin effect. You can have the short notes on incretin effect also. So remember which hormones are responsible for incretin effect, that is GLP-1 and GIP. Okay, and these hormones are also known as incretin hormones. So incretin hormones or incretin effect. So incretin hormones or incretin effect, if they ask, you have to write about the GIP and GLP. Now there are another examples also, and this is used in the treatment. What is the use? Why we are reading so much about this? Because this is used in the treatment of diabetes mellitus. Right? When we give the patient oral hypoglycemics, why we prepare oral hypoglycemics? Remember that first thing is it is easier to take, and it is having no intervention per se. Second thing is, when you take something orally, they are going to go in the GIT, right? And they are going to stimulate these two hormones, and via these two hormones definitely the insulin release will be at max, right? And especially in type 2 diabetes mellitus. Because in type 1 the synthesis is hampered, not the stimulation. Okay, so we cannot give it in the type 1, but definitely in the type 2 we are going to give it. Plus we do have a drug which are nothing but the DPP-4 inhibitors. An example, gliptins. All the gliptins, they are coming in the DPP-4 inhibitors. Now what they do is they increase the level of GIP and GLP-1. So what they are going to do is, what is their mechanism is, these gliptins are indirectly increasing the insulin via increasing the GIP and GLP-1. So final result will be increase in the insulin release. So the final result will be increase in the insulin release. Now also we can give the GLP agonist. So I can write also, I can give GLP-1 agonist. agonist. It can be used for the treatment of diabetes mellitus again. Example is exenatide. Example is exenatide. Okay, now what the next point? Next point is fifth one, right? And this is nothing but the glucagon and growth hormone, etc. Now the glucagon and insulin, they work inverse to each other, so we can write it as glucagon and insulin, they are inversely related to each other. When the glucagon is increased, definitely the glucose levels inside the blood will be rising, and as soon as the glucose levels are rising, what is going to happen? Obviously those high km glut2 receptors will be open up. This glucose will enter inside the beta cells of pancreas, and insulin will come again to balance the blood glucose level, right? So whenever the glucagon and growth hormone levels are high, the insulin release, they actually stimulate the insulin release, right? And next is beta adrenergic receptors. Beta adrenergic receptors. Now understand, on the pancreatic islet, the sympathetic system is having dual receptor system. Now, on the pancreatic islet cell, we do have dual receptor system. For the sympathetic system especially, that means it can increase and decrease glucose both depending on which receptor it is stimulating at max. Okay, so if it is stimulating the beta adrenergic receptor, definitely it is going to increase the insulin release and decrease the glucose level, right? So if I say, if someone is taking beta blockers, what is going to happen? Their glucose level inside the blood will be increased. Why? Because there is a less stimulation or less secretion of insulin, right? So that's why the glucose level inside the blood will be high. And if the glucose level are going to be higher, definitely this is going to contraindicated in diabetes type 2 or diabetes patients. Why? Because these beta blockers, they are going to decrease the insulin. And alpha receptor stimulation, if alpha adrenergic receptors are stimulated, right, so that is also going to decrease the insulin, right? So beta adrenergic agonist can be, we can give the beta agonist but not the blockers in the diabetic condition. So these are the factors. What they do, they are going to increase the insulin release, right? Now let's learn what are the factors which are decreasing the insulin release. Okay, so let's learn what are the factors which are decreasing insulin levels. Decreasing insulin levels. First thing, when we are talking about insulin, now remember the insulin also works through the negative feedback system, right? So first thing, first and foremost will be insulin itself. Now this insulin itself, that means when the insulin levels are high, it will give the negative feedback on the beta cells of pancreas, and that is going to inhibit the further release of insulin. So that is nothing but it acts via the negative feedback system. This is also the example of negative feedback system. Then the second one will be hypoglycemia. Hypoglycemia. We learn that the hyperglycemia increases the insulin release. Then obviously hypoglycemia, when there is a less levels of glucose inside the blood, it won't be able to open up these GLUT2 receptors. Why? Because it is having high Km. For opening of GLUT2 receptor or activation of GLUT2 receptor, we require high levels of glucose in the blood, right? So if the blood glucose levels are low, definitely it won't be able to open up the GLUT2 receptor. It won't be causing the exocytosis. Okay, so hypoglycemia will decrease the insulin, right? And physiologically it is also correct. So remember, when there is a low glucose, If you start releasing more insulin, definitely this insulin will come in the blood and it will cause further decrement in the glucose level or further decrease in the glucose level, right, which we do not want. So this is a protective phenomena which occurs in the body of a human being. Then we can give the potassium channel openers. Potassium channels openers, right? Now remember, when the potassium channel closes, what happens? The potassium is not able to go outside of the cell. The potassium start to accumulate inside the cell. But if you give potassium channel opener, what will happen? The potassium inside the cell will start going out more and more. Why? Because the channel is open for longer duration now. If the positively charged ion leaving the cell, definitely the cell will become negative, right? Positively charged ion leaving the cell with its positivity, definitely the cell will become negative. Okay, and if it is going more in the negative, what we call it as? We call it as hyperpolarization. Hyperpolarization. Remember, the normal polarity of the cell is usually negative. If the polarity of the cell is going more in the negative, even more than the RMP, we call it as hyperpolarization. Hyperpolarization, right? And any example of the potassium channel opener? That is nothing but diazoxide. That is nothing but diazoxide. And when it is given, now what we are doing, obviously if there is a hyperpolarization, less secretion of the insulin will occur. And when it is going to be helpful, when the insulin secretion is much more, and when the insulin secretion is going to occur much more in the cases of insulinoma, that is the tumor of or the cancer of the beta cells of pancreas, which is secreting the excessive amount of insulin. In that case, this diazoxide is going to help the patient to decrease the insulin release, right? Then we learn about the sympathetic nerve, right? That is, they are having the dual receptor system over here. So we can write over here sympathetic nerves. Now in sympathetic nerve, what we can write? We know that the alpha and beta both are going to act, right? But if I have to decrease the insulin release, definitely I need to activate the alpha receptors, right? So epinephrine and norepinephrine, like catecholamines, they act via the alpha adrenergic receptors. Adrenergic receptors, alpha adrenergic receptors, and they decrease the insulin release. Remember, these epinephrine, norepinephrine will be activating both alpha also and beta also, right? But they activate alpha more as compared to beta. Okay, normally they activate alpha more than the beta, and definitely they decrease the insulin release, right? If you just give the beta agonist, then only the beta cells will be more and more activated. But in normal physiology, the alpha cells will be more activated, and the net result will be decrease in the insulin secretion. And logically also it is correct. Why? Because when you are under the stress situation, you cannot allow the glucose to be low. At that point you have to have more glucose. Why? Because your body is under the stress, right? Suppose you are running in the jungle, right? And the lion is behind you. Now you need more energy at that time, right? More glucose in your blood, so that you can provide more ATPs to your skeletal muscle and you can run for your life, right? So that's why you definitely require more of the glucose. You cannot allow the glucose to fall. So that's why we have to keep the insulin levels low. So this is the normal physiology condition that is going to take place, right? So this was the fourth point. Now we'll move on to the fifth point. If, let's say, in the blood the potassium levels are low, what is going to happen? The gradient for the potassium in between the cell and outside of the cell, that is between the ICF and ECF, will be increased. More is the gradient, more will be the movement of the potassium towards outside, right? So in the cases of hypokalemia, hypo means less, this K is coming for potassium ion, emia means blood, right? So whenever the potassium levels are low inside the blood, that is known as hypokalemia, what is going to happen, that the potassium efflux will be increased. It is going to get increase over here, and efflux means the potassium is exiting out of the cell, right? Efflux means it is leaving the cell or exiting the cell, right? So obviously the potassium efflux is occurring, positively charged ion leaving the cell will make the cell again hyperpolarized. So over here what is going to happen, due to hypokalemia there will be hyperpolarization of the cell, hyperpolarization of the cell, and when there is a hyperpolarization, obviously the result will be decrease in the insulin secretion. Now there are some drugs which can cause this hypokalemia. The drugs responsible for it is, first thing is loop diuretics and also the thiazides, loop diuretics and thiazide diuretics, right? These two drugs are tend to cause the hypokalemia. Okay, let's move on to the next thing. Now the glucose increases the insulin release. We just now learned that when the glucose increases inside the blood, it causes increase in the insulin release. But remember, if you give a fake glucose, that means the structure is somewhat different but the overall composition is same, right? So such glucose is nothing but 2-deoxyglucose. What it is going to do, it is rather, when you give the 2-deoxyglucose, it will inhibit the glycolysis. It will inhibit the glycolysis. If the glycolysis is less, definitely the ATPs will be less, and if the less ATP is generated inside the cell, less will be the exocytosis, less will be the opening of calcium channel, less will be the exocytosis, and less will be the insulin release. So I can say that the net result will be less insulin release. Less insulin release. So these are the factors which inhibit the insulin secretion. Now, before ending this video, I want to say a few facts about the insulin. Nowadays, they are giving you the MCQs, and many MCQs already have been asked about these points. So these points are very important, and even if you write it in the your prof exams, theory exam, definitely you are going to win 1 extra mark for sure. Why? Because there are some scientists who done a lot of work around the insulin, right? So we are going to talk about that right now. So who did the insulin discovery? Who did the insulin discovery? It is done by the Banting and Best. It is done by Banting and Best. The next thing is the insulin extraction. The insulin extraction is done by Banting and McLeod. The insulin extraction was done by the Banting and McLeod, and remember, they're very important. Why? Because they got the Nobel Prize for this invention. So remember that they got the Nobel Prize for that. That is the insulin extraction. So these Banting and McLeod is very important. Then the insulin structure, how the insulin is actually composed and how it looks like. The insulin structure was given by Sanger. Okay, so insulin structure is given by Sanger. Remember, he also got the Nobel Prize, not only one Nobel Prize, but he got double Nobel Prize, right? So he got the double Nobel Prize. And one of that was the insulin structure. He gave the DNA sequencing of it. He gave the DNA sequencing of it, right? So these three things are very important as far as your the MCQs are concerned, right? So that's all for today's video. I hope you like the video. Please like, share and subscribe. Let other students also get this free information available, right? If you want any specific topic to be discussed, please let me know in the comments also. That's all for this video. See you in the next video. Till that time, keep studying, stay healthy and enjoy the learning.